All right, good morning, everybody. Welcome to the Friday webinar session. We've got a debate session on this morning, and it's what to do in a patient with bilateral, sort of small volume, 1 centimeter mid-zone stones. Um, so we got our two speakers lined up this morning, Dr. Elijah Rhode from UCT. He's going to be arguing in favor of tackling both at the same time. And countering that will be Dr. Gloria Phasha from the University of Pretoria, who's saying to do one side at a time. So we'll hear their thoughts and their reasoning behind that. I think we'll start with Elijah, and then Gloria will go with you next. Are you happy with that?
Yes, Prof. Thank you. Good morning.
Dr. Phasha, are you there?
Yes, Prof. Thank you. Good morning. Can you hear me?
Yes, yes, no, we can hear you clear. All right, are you happy if Elijah goes first?
Yes, Prof. Good morning. Thank you. That's fine.
All right, thank you very much. Okay, thank you, Eli.
Are you
Thanks,
struggling
Prof.
to hear me, Prof?
No.
Hey, can you hear me? Oh,
Yeah. Right, morning. Thank you very much. Thanks, colleagues. So this morning, I've been tasked with defending the position of doing single session bilateral retrograde intrarenal surgery to do both kidneys using one anesthetic and in one sitting. So before I say a word in favor of the stance, I first just want to be clear about what I'm defending, because I'm not here to argue that bilateral intrarenal or bilateral retrograde intrarenal surgery is for all patients with bilateral stones, because that wouldn't be defensible. But rather, I'm going to defend it for a specific patient which has been set out for us today. And I'm going to show you that staging is not a cautious choice, but rather it's a second avoidable surgery that's often dressed up as caution. So I just want to remind all of the patient that we're talking about. And we're talking about a fit adult, ASA 1 to 2, with normal renal function, normal pelvic calyceal anatomy, sterile preoperative urine, bilateral 10 millimeter mid-pole stones, and consequently probably a burden under 25 millimeters in total. Now, I'm going to start off by saying, first and foremost, that when you look at the literature, for every risk in bilateral retrograde intrarenal surgery, the risks are either absent in this patient or they're entirely avoidable. The sepsis predictors, the renal dysfunction predictors, and the reasons that older textbooks told us to do staged procedures is switched off in this patient, or you can mitigate it. So the question then becomes not, is it safe to do bilateral retrograde intrarenal surgery, or rather, is it dangerous? It can be dangerous in the incorrect patient, but the question is narrower and far more honest. And that is, can we justify doing two operations in this patient? And I'm going to show you by the guidelines, by the efficacy data, and by the safety data that the answer is no. This is the textbook ideal candidate for same session treatment. So let me prove it to you. I've got 5 claims that I want to make, and I'm going to set out to just run through them. And the first one is that major guidelines endorse or allow you to proceed with single session bilateral retrograde intrarenal surgery. The efficacy is equivalent, and you lose nothing on stone clearance by doing it in one stop. The catastrophes that will definitely be raised here today, everyone has a built-in mitigation over and above the fact that it's pretty rare. And then fourth, although there are genuine weak points, I'm going to concede them, but I'm also going to show you how one can control them. And finally, I'm going to show you what's probably most important for us, how it saves anesthetic, how it saves theatre time, and how it saves money. And this is probably the most pertinent factor in the South African setting. So, my opinion is one thing, but why don't we consider the guidelines? Because over the last couple of years, that's where the debate has quietly shifted. So you can read this one me. This is read this with me. This is the AUA statement for this year, 2026, on bilateral retrograde intrarenal surgery. And they say that clinicians may offer bilateral same session stone treatment. It's a conditional recommendation, and the evidence is grade B. Sure, great. I'm sure people will seize the opportunity to say the word is conditional, and I'm going to grant it. It is conditional, but it's a permission, maybe not a mandate. And what you'll actually notice is that compared to previous guidelines or previous years, that default posture has changed. It's gone from always staging these cases to there are some patients that are probably suited for this, which means that the data is shifting. The second statement from the AUA guideline is that clinicians should place a urethral stent if you're doing bilateral surgery or you've got a single kidney. And that probably mitigates the biggest argument that's going to be against bilateral surgery, which is the risk of causing sepsis or obstruction in both kidneys at the same time. So the safety net is built in. And then finally, our own guideline that we use most often, the EUA guideline of 2026, states that you should individualize it, stone size, number, location, and anatomy, but it does not prohibit same session bilateral treatment. So before we look at a single outcome, the position is this: two procedures is fine, but the guidelines say that you can do one. I guess we still want to see, does it work though? So the claim I'm going to make here is simple and it's strong in that you don't sacrifice stone clearance if you do it in a single setting. And I've got two meta-analyses to deal with this. So both of these come from 2025. The first one is from Rhode, and they look at 836,000 patients across 13 studies. And what essentially they saw is that when looking at stone-free rates in single setting versus staged, you've got a relative risk of 0.89, but the p-value equals 0.23, so there's no significant difference. The second one is another meta-analysis from 2025, and this one specifically looked at single setting, 1,218 patients. Once again, here, they say that the stone-free rate is 0.73, but here your confidence interval goes from 0.43 to 1.23, crossing 1. And so once again, it's not statistically significant that there is a difference in stone-free rates. So whatever else can be argued today, we cannot say that you clear fewer stones if you do a single setting surgery, because the highest level of evidence, meta-analyses, two of them, 2025, show that you have equivalence in the ability to get stone clearance. Now, you might reasonably ask, that's all good and well, but how does it compare head to head if you took single setting or you took a staged procedure? And I've got a study for you that addresses that. This is the only one that I could find, which is a direct or study that pits directly single session retrograde intrarenal surgery versus staged. And this is by Phasha and colleagues. And what they found when they looked at 63 single sessions versus 37 staged patients is that there's no difference in stone-free rates and there's no difference in the need for additional procedures. And they had a comparable stone burden in both studies, so 30.9 and 32.4. And then the number that becomes the cornerstone of this is operative time. 86 minutes if you do it in a single setting versus 139 minutes in total if you do it in two. So staging a procedure is not a more gentle way to deal with the stone. It's a longer, and I'm going to show you later that it's a more expensive option. The author's own conclusions in the study was that it would strongly consider single setting bilateral surgery in the correct patient. So I've shown you the guidelines and I've shown you meta-analyses that show you stone-free rates. And we've now noted that the operative time is also reduced. But maybe you want real world data. So I'm going to show you two studies here. We've got on the left a study by Castellani, and this is the largest series ever looking at bilateral surgery. It's 1,250 patients. But what's interesting about this cohort is the median stone size is 10 millimeters, which is our patient that we're considering 1,250 times over. All right. And what they found is that bilateral stone-free rates is 73%. Median surgical time, 75 minutes, and the need to stop early and abandon procedure only occurred in 6.8% of patients. But I think this is also important to note is, although it's rare to stop early, you also always have that safety net that you can stop early. A more contemporary study and more relevant to the technology that we have available is on the right. and that's the modern FANS suction sheath registry from 2025. This is a flexible and navigable access sheath or suction access sheath surgery. And what's interesting about it is it's held to a deliberately harsh standard where they look at non-contrasted CT at 30 days. And you'd notice that if you look at a lot of these studies, they often use ultrasound. But even with that, 75.7% of patients, so more than 3/4 of patients, had at least one stone or one kidney cleared of all stone in a single setting. And your reintervention rate was 2.6%, and you cleared bilateral or bilateral zero fragments was 42%. So the highest level evidence says it's equivalent. The only head-to-head says it's equivalent and faster. And the largest real-world series in outpatient says it works. So I think this closes the discussion on efficacy, and there's clear evidence that it has efficacy. But probably the heart of the matter is safety, that most people will argue. And this is the crux of the entire debate. The word that's often raised here is catastrophe, because if you block two kidneys, you get sepsis from two kidneys, then you potentially have what we call double jeopardy. It's a powerful narrative, but I'm going to show you through the data that's probably also a myth. So the cleanest refutation of double jeopardy in the narrative literature is from that FANS prospective registry that I showed you. 115 patients, all of them underwent same setting bilateral retrograde surgery. Cases of sepsis, 0. Transfusions, 0. It's not low, it's not acceptable, it's 0 in a prospective multi-center study. The other information that we also gleaned from that study is the ureteric injury rate, 1.7%. And of those that were injured, it was all grade 1 trachea injuries. No pelvic calloceal injury. The mean pain score was 1.7 out of 10, and 4.3% needed readmission. So when they tell you that operating on both kidneys causes bilateral sepsis, I want you to remember this slide, because this clearly shows that perhaps is not true, and especially so in the contemporary surgery where we have suction access sheets available. So this is only 115 patients. Perhaps that's small. We can scale it up by 10. We can go back to Castellani's data, which was the 1,250 patients. Out of their side effects that they had, transient fever, 10.7%, sepsis, 2%, transfusion rate, 1.3%, stopped early, 6.8%, and median minutes, 75 minutes here. So let's look at that sepsis. What's interesting about the sepsis component is that it identified independent risk factors for sepsis. And more over and above that is I want us to compare those risk factors on the background of our patient. You had a 5.99 or six times increase in sepsis if you had no antibiotic prophylaxis. I'm not sure who does surgery without antibiotic prophylaxis, but that is definitely a controllable or mitigatable factor. Kidney anomalies. As mentioned, we're not talking about a patient who has an abnormality in their function or anatomy of their system. So that is also something that is controllable. And then operative time, more than 100 minutes. If you think back to this large series, they're all operating at a median time of 80 and a median time of 75 minutes. That's all mitigatable. The only one that perhaps is not mitigatable is female sex. So later on, I'm sure it's going to be mentioned about the GRAND study, and they're going to bring up sepsis. And I want you to remember this slide, which shows that, yes, you can get sepsis. 2% out of 1,250 patients is not only manageable, but the independent risk factors are also controllable. So I want to show you one more safety number. Whatever they say today, they're going to say that the complication rates are higher in bilateral surgery. Okay? And that's true, but one has to discern what is a minor complication versus a major complication. In 836,000 patients in this meta-analysis, severe complications being Clavian Dindo 3 or higher was actually very low. They had a 1.22 relative risk with a p-value of 0.53. So it wasn't significant. And this shows you that there's no increase in the risk of significant side effects or severe complications, but rather minor. So the complications that end up getting reoperated or end up in ICU, that's flat or equivalent. There's no difference. But rather, I'm going to concede that the weakness is probably that there's an increase in minor complications, a bit of scratching on the ureter, hematuria, need for analgesia. Now, it's probably wrong to say that there's no weak points to bilateral surgery, and I think it's worth looking at them quickly because I can show you that I think that they're all controllable. So as mentioned, we have to concede there's more complications with bilateral surgery, more minor events, Clavian 1 to 2 events, more retreatment. And there's a study by Danilovich which looked at your overall risk of complications, and they showed that it was 40% versus 16%, so much higher in bilateral surgery. But you have to nitpick this a bit. The data is dominated by Clavian 1 and 2 problems, and that skews it. Severe complications, as mentioned, statistically insignificant. It's not increased. And then one has to consider the data that they're looking at. Most of the data that come out is a bit biased because you're considering 2 renal units versus a single renal unit. Just by virtue of what you're covering, you're obviously going to have more Clavian or complications related to 2 units. And one of the only studies that actually considered per renal unit complication showed no difference in complication rate. And I think that's an important thing to understand. So just because you have a higher risk of having minor complications is not a reason to subject the patient to a second surgery. What about the renal function? And I think this is interesting data. What about the renal function dip? So the question is, you're stressing both kidneys at the same time. What about the renal function? And I think it's a fair question. And once again, reflecting on Danilovich's group, they answered this question directly by following the trajectory. And what they found is that when you compare baseline to postoperative immediate and postoperative day 3, there is a difference and the renal function dips. All right. And if we stopped examining at that point, perhaps an opposing argument would have grounds here. But if you go on to examine this at postoperative day 10 and postoperative day 30, the statistical significance, there's no statistical significance. It's statistically insignificant. This shows you that the dip in renal function is transient. It's just a little bit of a dip. It's not that the patient falls off the cliff. And I think this is an important concept to consider, that yes, you're going to have a dip by postoperative day 3 if you started at a normal baseline, but that will improve by day 10 to 30. So the safeguard here in the data is to keep your operative time under 120 minutes. Everything so far discussed has probably been about the patient, but I think an important consideration here is, what about the system? Because patients are treated in a system, and here in South Africa, with our limited resources, this is an important concept. If you look at the maths, it makes sense. If you're doing a single operation versus 2 operations, every time you need 2 anesthetics for a patient, and you put this patient at risk twice: airway events, cardiovascular instability, post-operative nausea and vomiting. And if you've got an elderly patient, they can get delirium or cognitive dysfunction. And that's purely based on exposure. Every time they have an operation, you roll that dice and you can get one of those. So one anesthetic is actually a safety measure. It means the patient has one induction, they have to emerge once from that, and they have to have one recovery. The frailer patient, in fact, may well benefit from having a single procedure. There's a few resource wins that I also want to look at, and it's 3 in total. We've mentioned this: operative time. You operate for shorter if you do it in one sitting. This is an interesting one, and it's that you use significantly less disposable devices. And especially in our contemporary practice, there are more disposable scopes, more disposable access sheets, and you definitely decrease the amount that you use. Hospital stay. Now, you would think to yourself that you were operating on a person and you're doing it in one setting and you caused sepsis, if you thought that way, or you caused a problem, that they would stay longer in hospital. But it's actually been statistically proven that the hospital stay is similar, which means that if you're saving cost on equipment, you're operating less for a shorter time on the patient, and the patient stays an equivalent amount of time as someone who had 2 surgeries, you're effectively saving money. So let's make it local. If you have a patient that comes for an operation and they have to come twice, that's 2 hospital admissions, that's 2 theater slots they're going to occupy, that's twice that they're going to be off from work for X number of days. And if you're servicing a population like out in the garden route or wherever, this patient is coming twice back, and back for the operation. So I think it's an important thing to think about in the background of a constrained public service. And this shifts the argument then out of the efficacy and safety sort of domain to thinking about equity, and that this probably provides more patients with care and allows you to operate on more patients. So this is not a license for recklessness. I can't say that you can operate bilateral kidneys, same setting for every patient. But I do think that there's some caveats of how you can do it. And that's firstly to select the right patient. Fit patient, normal renal function, normal anatomy, sterile urine, burden of disease under 25 millimeters. And then I think if you go through these steps, you treat the easier side first. And if you have to bail, you bail. That means you can clear one statistically. Mandatory ureteric stenting. The AUA endorses it, and that's going to help protect you against bilateral obstruction, bilateral sepsis. Suction sheaths. If you have that available, we know that lowering that intrarenal pressure will prevent infection. And that's sort of the biggest thing we're worrying about, yeah? And then capping your operative time and saying that the ceiling is less than 120 minutes. That's also going to reduce a lot of the side effects. And then, as mentioned, they've only needed to abandon procedures in 6.8%, but you've always got that fail safe. You can do one. If you run into trouble, you can abandon the procedure. So those are my thoughts, and those are the reasons that I think one should do bilateral retrograde intrarenal surgery in this patient.
Fantastic. Thank you very much, Eli. Extremely well argued from your end. We'll ask you obviously to wait around. I think we'll save the questions for the end after both speakers have had a turn to argue their sides. Dr. Phasha, I see you sitting up there. Thank you very much.
Good morning. Are you able to see the slide?
I can see it here. I don't know why we don't see it there. Good luck.
Thanks, Vika. We can see your slides.
Good morning, colleagues. I'll be representing the stage management in patients with a bilateral 10 millimeter mid-zone renal calculi. And I'm presenting the case for sequential intervention and why it is preferred. As stated, I'm Dr. Gloria Phasha, and I'm representing the University of Pretoria. So I'll start off this conversation with why bilateral stone formers are such important patients. We've seen that about 15% of these stone formers, 15% of the patients who present with stones have bilateral calculi, and these patients impose quite a significant burden on the healthcare system. These patients usually have an underlying confounder, and it's found that about 42.5% of bilateral stone formers have an underlying metabolic condition. And it's further been shown that the more the patient has confounding metabolic risk factors, the higher the fold or the chances of having bilateral renal stones. So these patients are challenging for us to manage because they present with needing possibly multiple procedures, unplanned hospital admissions due to the prevalence of recurrent stone formations or infections, and this potential risk also of urinary tract obstruction or injury with intervention. And these patients have underlying morbidity. So they are a population that already have a poor post-operative surgical outcome potentially. And thus the traditional approach to a staged intervention is what we see. So when we manage a patient, we don't just look at stone burden, we look at the patient holistically. And my argument today is to say that we're not just treating 2 stones and 2 kidneys, we're treating a patient. And the clue here is that we want to look at patient factors, stone factors, and also institution capacities. So with bilateral renal calculi, we should first ask what is making this patient present with bilateral stones? Is there underlying metabolic abnormalities, dietary, genetic, anatomical, or systemic disease that we need to look for? And optimizing this patient not only includes operative management, but also we need to preserve quality of life, correct any abnormalities, and also in keeping with the patient's preference and also socioeconomic factors. And obviously, we also look at the stone itself. We want to achieve a good stone clearance. So As my colleague has already stated, we look at stone size, the number, the location, the stone composition, the patient's anatomy, if they're symptomatic at the time, and our aim is to achieve a stone-free rate. At the end of the day, we want to clear this patient of stones, and we also want to provide appropriate treatment to avoid recurrence. And a balanced approach to surgical management basically is maximizing stone-free rates while minimizing risk, and also obviously wanting to minimize anesthetic exposure for the patients. And this improves patient convenience. It does actually, in turn, as you'll see, reduce the healthcare costs from unplanned admissions, with the patients coming back with unexpected admissions. And a lot of the studies that are pro bilateral same sitting intervention are very highly expertise centers. They've got high volumes, they've got subspecialists that deal with endourology on a daily basis. They've got teams that work with patients that have high stone burdens. These teams have clear protocols on how to manage these patients, and these patients also have immediate access to high care admission, interventional radiology, and basically the sector in itself, in comparison to our sector, is something we should also consider. So for bilateral stone disease, so before we get into the merits of the option for management, I think it's important to note that the bilateral nature of this patient that we speak about is information within itself. So before asking whether or not we're treating this patient in the same setting, we should ask, what does the bilateral stone phenotype tell us about the patient sitting in front of us? Can we clear both kidneys in one setting? And if we're honest, is this patient actually an appropriate candidate for single session bilateral intervention? And you'll see my colleague, a lot of the studies that were quoted are very small studies, because this patient that we describe is a textbook patient, as my colleague has said, but in realistically in our setting, are these patients textbook patients? So just looking at the confounders, what kind of patient we're dealing with. There's quite a few studies that basically help us get to an understanding that bilateral stone formers can come in, they come in at younger onset, they've got more stone events. These patients have underlying metabolic abnormalities. We find with the Racine and Litt et al., which was a retrospective study which had 3,905 patients. They found that with metabolic syndrome was independently associated with bilateral stones, and these patients just had a greater post-operative risk, irrespective of their current presentation. We also note the retrospective study by Zeng et al. So this study is basically a study that shows us that they looked at 555 patients, and they found that bilateral stone formers had a metabolic profile that was important to look at. There's also a study that I'd like to look at when you just look at the slide by Howe et al. So Howe et al. In 2024 looks at metabolic syndrome and infection post flexible URS. In these patients, they looked at 1,110 patients, and they had a cohort of metabolic positive patients and metabolic negative patients. The outcomes of these patients, they found that there is relatively a lower post-operative fever, sepsis, and septic shock rate. But of importance, patients that had underlying metabolic phenotype or syndromes had a higher risk post-operatively, irrespective of complications. They had post-operative fever, 88 patients had post-operative fever, and 67 of those patients were metabolic positive patients. 49 patients presented with urosepsis, and 29 of which were also part of the metabolic group. And 7 patients went into septic shock, but only 1 of the 49 urosepsis patients went into shock. So that shows you that these patients have even low reserves. They go post-operatively, can present immediately with septic shock. Another study mentioned quite well, which speaks about, or it basically is a study that is used here in this debate to show that bilateral intervention in the same setting is actually a good option. But one thing we need to check here is that this study is done in a small population, and that shows you that this intervention is only for extremely small subset of patients. And can this be reproducible in the bigger scheme of things? A study of 115 patients in a population that we face in South Africa isn't really equivalent. What we found in this study was that the stone-free rates were comparable with staged and bilateral intervention. But what my colleague forgot to mention here is that there were longer operative times, and we found that longer operative times are an independent single risk to sepsis and infection and complications for these patients. Now, even with good technology, with the FAN study and a suction sheath, as my colleague has said, the stone burden or the stone-free rate is still comparable. So why expose the patient to a same setting anesthesia, which is a longer time, only to produce a similar stone-free rate? At the end of the day, the aim for this patient is to make sure that they are stone-free as soon and as safely as possible. So the flaw with this study is definitely that it is too small of a study, done in a highly skilled centers that primarily deal with endourology, and this setting is not really producible in our setting. So when you look at the How metabolic syndrome study, when you take into account FANS, which has great technology, which has improved comorbidities, we're still not getting a good or a higher or superior stone free rate compared to a bilateral or a staged approach. So why even take the risk if we look at the outcomes and there isn't much of a difference? So when looking at our patient, yes, we know that the patient has a single 10 millimeter calculi bilaterally. We're not really sure of the Huntsville units. We're not really sure of the patient's anatomy, their current renal status, the symptoms that they're presenting with, and we haven't really gotten a urine culture. So we are assuming that this patient is an extremely fit, healthy patient that subsequently just has two bilateral renal stones, and that really isn't the case clinically. It's just a theoretical assumption. So we just looked at the modalities, and the three modalities that are stated in the EUA guidelines, which my colleague covered quite well. And in this case, there are three distinct strategies that can be used, but we have chosen the same setting intervention that we are currently debating. So the next part of my talk is just going to compare same session bilateral RIRS with a staged two setting intervention. And here they speak about stone-free rates and the Calvin-Denuc complication system is used to classify the patient's post-operative complications. So just to note that most of these studies have used a residual fragment size of between 2 to 4. The imaging of choice is a non-contrasted CT scan. The timing of imaging is from between 4 to 12 weeks, and residual dust fragments are included as a portion of residual fragments. And I've just stated there why we use the CD classification, and to say the higher the CD classification goes, the worse the outcomes are. So when you look at the Lipane study, which my colleague already stated, it was it showed no stone free advantage. There were okay, so it showed that the major complications tripled, and there was retreatment, which was unexpected. And so the benefit that is being placed in front of us to say that the same session intervention of the bilateral stones is superior is not the case, because a lot of these patients do present with unplanned readmissions, and that is where the cost benefit is lost. If these patients are coming back, to the healthcare system, have we effectively treated the patients, or have we just treated the stones without looking at this patient demographic and how they fan post-operatively? So the take home for Lepain was that bilateral same-section RIRS achieved comparable stone-free rates, but at the cost of longer operative times and significantly higher minor or major complications and retreatment, particularly in elderly patients or patients with comorbidities or underlying comorbidities. And as I started my talk, these patients who present with bilateral stones cannot be assumed to be healthy, no comorbidity burdened patients. We need to look at the fact that this patient is a bilateral stone former, and there's a reason why this patient has formed stones in both kidneys. And these patients are patients we need to care for just a little extra because of how they fan post-operatively. The other study that my colleague also spoke about was Rhode, and it was also looked at same-session intervention. And they basically found that the overall complications were higher in the staged group compared to patients that had a I'm sorry, I'm just trying to move this thing. Okay, so the advantage of one session was fewer planned anesthetics, which was an advantage which was offset by significantly more unplanned admissions. So as I said, yes, these patients can go home on the same day, but they do come back with unplanned admissions, and that causes a burden on the healthcare system. So in Rhode, if you look at the take home, they had lower stone-free rates, there was higher overall major complications, there was longer operative time, longer hospital stay, higher retreatment rate, and in the patients where they did PCNL, they noted higher transfusion rates. And the Pergades et al. Study, this study is the GRAND study. So the GRAND study is a study that looked at quite a big number of patients. It is a very large German nationwide real-world analysis. And it was important because it adds a different scenario to the bilateral stones. Firstly, you see that with the recruitment of these patients, it's 833,000 patients, but only 6,904 patients had same session bilateral interventions, which is about 0.8% when you look at the intervention that is chosen. And that speaks to the fact that there's such a small marginal subset of patients that benefit from the strategy, because a lot of the patients don't come in as just healthy non-comorbidity patients. So they, even with the discrepancy of the amount of patients that had staged interventions and the patients that had bilateral same-setting intervention, there was an adjustment for the results that were found. But with the adjustment, we found that same-session bilateral intervention was associated with substantially higher odds for transfusion in hospital mortalities, acute kidney disease, sepsis, myocardial infarctions, ICU admissions, and UTIs. So the FAN study that my colleague spoke of, which is the study that a lot of people quote, but there was more to it than just looking at the stone clearance rate. They found that bilateral success is the product of two independent probabilities, which was the fact that the patients had highly advanced intervention. But even in expert hands with modern suction sheets, there wasn't a real comparative benefit for stone clearance. And the outcomes here were accepted under very strict selections. And these patients still had complications with UTIs as well. And we need to remember that the cost is not only a financial cost. We need to look at the burden of sepsis and infection in a world where we want to have a good antibiotic stewardship. We don't want to increase patients' risk of infection. And in these patients who we know that they tend to come back into the system, they present as recurrent stone formers, we don't want to further increase their risk of sepsis because these patients tend to be in the system for much longer. And we also need to look at the physiological cost, which is important as much as it has been downplayed. The transient EGFR fall is measurable. So the Danilovic et al. Study, which was a prospectively sampled creatinine before surgery at immediate post-op, 3, 10, and 30 days. And they found that patients undergoing bilateral intervention for stones had up to, with 20 millimeter per side stones, so had early EGFR deterioration. And the point being that the insult on bilateral, on the bilateral system symptomatically, we won't have another system to compensate. And they also found that the operative time is a modifiable driver. So prolonged intrarenal irrigation and raised intrapelvic pressures were the mechanisms that show the worsening outcomes for these patients. So same session bilateral intervention added about 25 to 28 minutes of operative time. And this then was a confounder in how these patients presented post-op. And we also don't want to be in a place where there's no physiological reserves if one side fails. So for post-operative obstructions, clots, edemas affecting a single treated unit is not as worse as how it would be if it occurs in the same side, in the same setting. And my colleague did raise that in about 6.8% of cases, this intervention was aborted. And we should ask ourselves, 6.8% does seem minimal, but is it worth exposing our patients to such a big risk when we don't have a clear stone-free benefit when we compare the two interventions? When looking at most of these studies, they speak about operative times and how the operative time is an independent factor as to how these patients do post-operatively. So the study by Whithurst et al. In 2020 looked at the factors affecting operative time during this intervention. And they found that operative time was widely influenced by the patient itself, the stone, and the surgeon factors. They found that larger stones with higher stone burdens were more complex, but patients that had high BMIs, previous surgeries, and anatomical abnormalities were associated with longer OT time. And surgeon experience was also a factor that was mentioned. The choice of access sheet, the use of the types of laser and bilateral surgery increased the OT. And the take home there was that bilateral surgery in high stone burden patients was a key driver for longer operations. Lane J in 2020 also looked at operative times. And we find here that the sweet spot for operative times without complications is about 48.7 minutes. So once operative times get to about 64.9 minutes, it does worsen complications. So longer operative times increased complications and up to 3 times more higher complications when the surgery goes up to about 200 minutes compared to less than 60 seconds. And the take-home message here was that we aim to achieve times of less than 90 with feasible complications. And as my colleague stated, the average of a single session staged approach is around 86 minutes, and we found that 90 minutes is still appropriate with minimal complications. And Gasso et al. In 2021, they looked at the overall complication rate, which is about 9.4%, with major Calvian complications at a 2.3%. And most complications were infectious, bleeding, ureteric injury, and perforation. And the risk factors here, still, as we say, long operative times, which is what occurs with bilateral same-setting intervention, a higher stone burden or complexity, and we've already stated that this is a bilateral stone former. Is this a patient that is really straightforward? And patients that have underlying comorbidities, and we've already noted that with bilateral stone formers, we have to concede that there might be an underlying reason why they are presenting with both these stones. So they've noted here that we need good, proper patient selection, surgical plan, and attention to operative time to reduce complications. And in our setting, do we see this patient? If these studies already can only recruit about 0.8% of these patients in these studies, do we actually realistically see a patient that benefits from bilateral intervention? There was also the study by Danilovic et al., which was a prospective study. And the take home here also was that it's a study that my colleague already stated. And here the intervention was the stenting placed in the kidney and removed by day 10. So here the take home is that the same session bilateral intervention is achieved similar stone-free rates, but required 27 minutes longer and had more complications and ER visits when compared to staged intervention. So is this intervention feasible in our sector? So when we look at the South African stone literature, there's a gap in the actual literature that we can use. So as we sit here, we can't reproduce these interventions in our setting. Most of the studies happened in multi-center cohorts from Turkey, India, Egypt, China, and the UK. And how are these studies comparable in our setting? The institutions that were used were institutions that had high volume experience centers. There was a large number of retrograde intrarenal surgery being performed on a regular basis in these centers by subspecialists that specialize in endourology. In terms of the medical team, it was surgeons that have had substantial experience with flexible URS, and including URS in difficult and bilateral stones. The centers had experienced anesthetic teams, nursing and endourology teams, which had a familiar experience in prolonged endoscopic procedures. In terms of the equipment, as my colleague had already said, with the fans, they had high quality disposable ureteroscopes, good laser systems, access sheaths, suction systems, baskets, imaging and stents. And I'm not sure if we can safely say that this is the same in our setting. And in terms of post-operative care, they established patient selection quite clearly. As they say, it's a fit, healthy patient with a relatively moderate stone burden. And even when they took these patients to theater, they had ICU beds, emergency theater, and interventional radiology on standby. So as we can see, there's nothing really is given up. So the pooled stone-free rates are statistically indistinguishable. Staging costs no clearance. So the two strategies at the end of the day do not produce a superior stone-free patient. There was lower overall morbidity with a staged approach, overall complications, and minor complications quite high at 2.55, and they both basically favored the staged arm. There was fewer unplanned returns in stage settings, so unplanned additional interventions in the same session bilateral intervention, we found that these patients came back to the hospital more than patients that had stage intervention. And obviously, once you work on one side, you have a better sequential learning. The stone composition, laser behavior, ureteric caliber, and if you have any access difficulty on the other side. So you don't need to abort while intra-op. You can plan for these patients clearly. And you also have a protected kidney. So one unit is not touched, even if there's obstruction and there's a stent placed. You have a patient that has one system that has been worked on, and there's a reserve as well. And we've also found that it's shorter and safer. So about 25 to 28 minutes shorter with lower cumulative irrigation load, less fatigued surgeon in a long case as well. So there were quite a few arguments on why same setting is important. So they said 2 anesthetics carry cumulative risks, but we did find in the studies that I've already mentioned that the 27 to 28 minutes longer operative time with bilateral treatment and increased complications. Staging means 2 admissions, 2 stents, 2 recovery. This is a legitimate that there's a 65% higher risk of unplanned intervention with same session. And the question is the total burden of treatment and not simply the intraoperative time itself. The bilateral series where we saw with fans, where they used suction sheets, squid fibers, disposable equipment, did not show a benefit or a superior stone-free patient at the end of the day. And they noted that second anesthetic may be more dangerous for the patient. And this is legitimate for patients who are unwell, who might not be able to tolerate a second anesthesia. But that is a very small subsection, and can that be translated in the bigger scheme of things? And we have a smaller, low burden, easily accessible stones, as they've said, which might only add about 15 to 20 minutes extra in the procedure. But these are patients that were done in highly skilled endourology centers that had experienced surgeons with high volume of these patients that they saw on a daily basis. And also we had a conversation about the geographic or social barriers that may make a second admission unrealistic. Patient circumstances definitely matter, but convenience should not modify the decision to override what is acceptable medical practice. And basically here I've outlined the traditional approach to how we treat these patients. And there are actually studies that look at adjuncts. So the first option wouldn't count in the setting because it speaks more to SWL, but there are settings where they've used external physical vibration devices, which was a safe, effective, non-invasive adjunct to the initial intervention. And this was done in 2025 in a multi-center study, which wanted to look at the optimal effects of EPVL. And they found that it was a good adjunct as well. Something we don't have in our system, but it is something to look at as an adjunct. So we can add adjuncts to our first session, as opposed to just saying we want to go in at the same time and intervene. So just the points I wanted to leave with everyone, that same setting intervention does not produce better stone clearance outcomes.
That's nice. Please bring.
But everybody who's not presenting,
Because
sorry, Gloria, you may continue.
Okay, so we found that there isn't a real stone-free difference with staged or same sitting intervention. So if our aim is to clear this patient's stones, why are we taking the risks that come with bilateral intervention for these patients in a setting where we can't reproduce the same factors that were put in place as you see with the FANS study? Same session doubles minor and roughly triples major complications, which we saw is quite significant, especially with the larger pooled data sets. And the fewer procedure argument weakens when we look at the unplanned additional interventions that happen with these patients. Planned sessions saving was partly repaid by unplanned admissions with complications. And same session remains right for selected patients, and we definitely agree to that. But bilateral stone formers are patients that already we should red flag as patients that are high risk patients. And we need to be very careful with how we manage these patients, especially if there's no reproducible stone-free benefit for these patients. I think that's it. Yeah.
All right. Thank you very much, Gloria. Excellently argued from your end as well. I'm going to offer both speakers a chance for rebuttal, and then in the interim, I'll put up a couple of quiz questions here. Let's launch both of these. They're both launched. I can only launch one at a time. Apologies. Let's launch this one rather. It's probably similar. Okay.
Sure, sorry. Great. Sorry, there's one. Thanks. Yeah, so just very briefly, thank you very much. I appreciated all those insights as well. So I just want to touch on two things, and that's the catastrophe narrative and the grand study, which I probably didn't go through. So I just want to run through everything and sort of a rebuttal. Bilateral sepsis is catastrophic. We saw in the FAN study, 0 out of 115. And when they looked at 1,250 patients, 2%. And we saw that all of that 2% had 3/4 of that were modifiable independent risk factors. Bilateral obstruction, AUA is telling us, put in stents if you're going to do bilateral one-stage surgery. Bilateral ureteric injury, 1.7%, grade 1 only, no high-grade injury. And in fact, the data on long-term is no increased strictures. Risking both kidneys at once, I think I demonstrated. You're going to drop your renal function on day 3. It's going to climb back up to normal, day 10, day 30. The headlines. So the biggest study that's against single stage is this, it's called the GRAND study from Pagides. And if I looked at this, it would be horrifying. Sepsis, acute kidney disease, transfusion, ICU admission, in hospital, mortality. But the devil's in the details. Firstly, it's an administrative database. Once again, you're comparing 2 renal units to a single renal unit. We don't know stone size. Bilateral patients had worse baseline characteristics. This makes sense. Who do you want to get through a single surgery? It's that patient that you dare not take back again. So in this database, the most sickly patients got single setting surgery. That confounds your data. Were they sick and had poorer outcomes because of their comorbidities or because they had bilateral one-stop surgery? And then finally, there was a published rebuttal letter on this grand study that also mentioned these factors. So database association does not mean causation. Yes, who should get stage surgery? Abnormal renal function, you got one kidney, you got sepsis, you got anomalies of the structure, you've got a very high load, and your anticipated operative time is more than 120, but that's not the patient we're discussing. So I think if we look at the data, we've got equivalent efficacy, we've got equal severe complication risk. We half the amount of anesthetic needed, 86 minutes in total versus 139 minutes in total. So you have to combine both operations and compare it to single setting. One admission, not two. For this patient, I think the evidence shows that if you stage this patient, you're giving them an avoidable operation. Thanks. Stop sharing.
Thank you, Eli. Gloria, from your side?
Okay, I think I had already sort of covered these points. My colleague is very right. These studies speak about bilateral stone forming patients as being very sick patients. And that's why I started the conversation about looking at the patient holistically and not just the stone burden. The patients that benefited from the same setting were extremely ill patients. And I agree with that point. The fact that this patient is not just a healthy guy who's coming in with no complications. And I think presenting this patient as a patient who does not have a clue for us to think, is this patient really a healthy, fit patient who will never see on the system again? Or is the fact that they're presenting with bilateral renal stones a clinical red flag for us as responsible clinicians to say that this patient has developed two stones in two separate systems? We should worry about this patient. We should work up this patient because this is a high-risk patient. This is not a patient, as argued by my colleague, is a patient that we think we should never worry about. We've shown already when I was classifying the patient type that these patients initially present quite young with quite low stone burdens. But as you look at the patient's trajectory in the system, they represent and as they represent, we retreat these patients. It is not true that once we give them the one setting intervention that we never see these patients again. These are high-risk patients. They've got two bilateral stones, and therefore these patients need to be worked up quite carefully. The other thing I want us to just look at is the fact that the reason why a lot of these studies that are pro same setting intervention have very small patients is because the patient selection for this intervention is extremely careful, and it is an extremely small portion of society that can benefit from this intervention. So if we're debating an intervention that benefits an extremely small subset of stone disease, which is quite a big burden in our healthcare system, what is the benefit? Especially because this intervention has not been proven to be superior for stone clearance. They do not have a better stone clearance rate compared to a staged procedure. And we cannot overlook the fact that sepsis and infection are a burden of the healthcare system. We can't be okay with the fact that exposing this patient to longer operative times increases their risk for infection. We've already identified that the underlying conditions for this patient make them high risk post-operatively, even before we intervene. A bilateral stone former as a patient we do need to worry about and putting measures in place. Now, if we decide that this is the route that we choose to take for these patients, a lot of the centers had an ICU bed that was already found for the patient, readily available, treated by nurses that were skilled in endourology. They had set protocols that showed what needs to be done once a patient presents with a certain complication. They had reduced their intraoperative times with certain techniques that I think might be very difficult to reproduce in our setting, which is we need to be realistic. What setting are we speaking about? And are we able to get an ICU bed for these patients before we take them to theater? How difficult is it for us as colleagues to even get a high care bed for our patients in our setting? And that in itself speaks to the cost burden for this patient. It's not just looking at the cost for a single anesthesia, single operation. The other factors that are put into place to make sure that this patient has good outcomes are a cost within itself. And it's something that we need to look for. And I think, as my colleague rightly states, stenting is very important. Once we've deobstructed the system, we can then have a planned, clinically sound plan on how we treat our patients, because we have deobstructed these patients. And the FAN study does speak to that. But we need to be careful. A lot of the research at the moment that is pro a same session bilateral intervention, it has an extremely small patient recruitment. And I think that is also something that we need to note. It's not enough information for us to confidently say, this is what we will produce in the South African context that doesn't have enough literature. Thank you.
Awesome. Thank you very much, Gloria. And thank you to both speakers. So I don't know if we have any questions from the floor. We are a little bit over time. I'm sure there are a few. Prof. Lazarus has a question, yeah?
Thank you to both debaters. Very engaging topic. I just want to talk a little bit about the fact that I think this is a particularly rare situation. In other words, how often do we have 1 centimeter stones in exactly that position? I think far more likely the case is that you've got a patient who's got a symptomatic stone on one side and an asymptomatic small stone that is not causing bleeding, infection, pain. So I suspect in the largest series that was shown, which was said to be 800,000 patients, but was actually only 7,000 patients, the Andrade paper. You just wonder how many of those were in fact asymptomatic small contralateral stones that were being treated. Probably most urologists wouldn't have recommended treatment. So I think that's not clear through this debate how common this clinical situation is. I also think that we've got to be a little bit cautious, and I'm going to show how close I am to obsolescence here, and I'm as guilty as anyone. But using AI can lead us into trouble. For example, one debater said that there's triple the severe complication rate when you do it bilaterally, and another colleague said that there's no increase in severe complications. So the truth must lie somewhere between. So we're presenting alternative facts as a artificial intelligence model is trying to find persuasive facts. I think we've got to remain critical. And perhaps I can end off by saying that one person showed a picture which showed stones outside the collecting system. So AI thought that stones were outside the collecting system. So we need to remain critically involved. I wasn't able to find one paper by Gao in the world literature. So I think we need to be sure that the things that we quote do in fact exist. Sorry, I'm showing my age, but just thought I'd make that comment.
Right. Okay, well, we are well over time, but I think this was a very engaging session this morning. Two fantastically well-presented talks. And I think either way, I don't think there's actually a wrong answer. I think everybody both argued their cases quite well. So thank you to both speakers. Thank you to all of our participants, and everybody have a lovely weekend. Enjoy the box tomorrow, and we'll see you all next week. Cheers.